Hello everyone. We have a 83-year-old lady who come to emergency department from home due to poor appetite, fatigue, diarrhea and confusion. She was recently hospitalized with pneumonia for which she was treated with broad spectrum antibiotic. Well, since that time she had worsening diarrhea. Diarrhea is foul smelling, doesn't contain any blood. Temperature is low grade fever is there, BP is on the lower side, tachycardia is there, poor skin texture. Well, there's no other interpretation other than dehydration. But we should not forget her age is 83. That point should be kept in the mind because this is a very good clinical sign, especially in children and young adults. But in adults, it is an indication of dehydration. But remember, elderly people already have some sort of wrinkling in the skin also. Well, as far as lab reports, sodium is highly reduced. Bicarbonate reduced, that indicate metabolic acidosis. So we are getting hyponatremia with bicarbonate. Normal sodium level is 135 to 145, but in this 125, hyponatremia is there. And BUN is increased. Creatinine is almost normal, but this is highly reduced. If you look into the ratio, 62:1:5. The ratio is almost, you can say, 35:1, something like that. Okay. Well, the rest, all the reports are in the normal range. TLC count is 18,000. It is increased. The stool test is positive for Clostridium difficile toxin. How come this happened? Because the patient was treated with the antibiotic. Okay. But now the question is, what is the most likely present in this? So what we expect in this, well, the clue that we had is patient had clue are patient was dehydrated. Of course, this could be diarrhea. Why diarrhea? Because of Clostridium. There is metabolic acidosis is there, and hyponatremia is there. These are the thing that we are getting it. So what we expect in this high renin, high aldosterone and high ADH we expect. Why this? So volume status is essential for diagnosis and causing hyponatremia, sodium less than 135. So it's really a case of hyponatremia. As I told you, sodium is just 121. So this suggests depletion of salt and water. Even the BP is low, pulse tachycardia, all indicate dehydration. So in our recent patient has a poor oral intake, diarrhea due to Clostridium difficile infection is there. Laboratory infusion of pre-renal azotemia. Very, very important, the BUN to creatinine ratio more than 20:1 is a highly suggestive of pre-renal failure. In our case, it is 40:41:1. Okay, definitely what I wrote was 35:1. Okay, my mathematics is not so good, but it is 41:1. If I hope this is also good, but definitely more than 20:1. So tachycardia, hypotension, decreased skin texture, absence of peripheral edema strongly suggests that patient has got dehydration. Now, sodium is less. This occurs due to multiple pathway mechanisms that elastate body prior to restore euvolema at the risk of hypotonicity. Decreased renal perfusion lead to decreased tubular sodium delivery, and that lead to stimulation of renin, angiotensin, aldosterone system, and that causes increased sodium reabsorption. How come? Let us see. This is a nephron. And normally aldosterone comes, it tends to absorb 2 sodium with water. Sodium is absorbed actively, water follows passively. The 2 sodium come in One H ion will go out, one potassium will go out. Why? Two positive particles have entered the body. As per law of electrostat, body has to excrete two positive particles, one H ion, one potassium goes out. Now when dehydration occurs, what the body tries to secrete more and more aldosterone. More aldosterone will try to absorb more sodium with water. Okay, but now two extra sodium have come in. The body has to secrete one more H ion and one more potassium. So that lead to hypokalemia, and that lead to metabolic alkalosis. Why H ion is going out? So, but this sodium water will absorb, will try to maintain the normal plasma volume. Okay. So now we understood how the sodium will be absorbed by renin-angiotensin's RAS system. But in addition to that, there is non-osmotic stimulation of ADH also occur. Well, this again the nephron, and we know very well ADH comes and get absorbed in the collecting tubule. It absorbs only water. It also absorbs urea. It has got ADH got no role in the absorption of sodium, but it absorbs sodium and urea. It absorbs water and urea, and that's the reason urea BUN is much more than creatinine. So non-osmotic stimulation of ADH, this occurs due to angiotensin 2. Hypovolemia stimulates stretch receptor in the left atrium. Hypotension stimulates baroreceptor in the carotid artery. These are the ones which contribute to increase ADH secretion. So now let me tell you some beautiful flow chart, mechanism of hypovolemic hyponatremia, what happened and how body is going to compensate. So sodium and water loss. Solute here means definitely sodium chloride. This lead to reduced renal perfusion, hypotension and hypovolemia. Hypovolemia lead to hypotension. Hypotension will lead to reduced renal perfusion. So hypovolemia lead to left atrial stretch receptor stimulation. Okay. Then hypotension lead to stimulation of baroreceptor, which lead to increased ADH, and that lead to increased water reabsorption, and that contribute to hyponatremia. Okay. And reduced renal blood perfusion lead to activation of RAS, that lead to angiotensin 2, and that lead to increased thirst, and that lead to increased water intake. So this is in summary regarding mechanism of hypovolemic hyponatremia. Ultimately, that lead to salt and water retention, helps correct hypovolemia by ADH. How in the setting of ongoing ATA level will remain high, not low until hypovolemia is corrected? Option C. Infusion of normal saline is a treatment option for hypovolemic hyponatremia as it replenishes body depleted salt stores. Restore euvolemia, shut off non-osmotic stimuli for ADH release, which I mentioned in the previous slides. Option A and E, high ADH, high urine sodium, and option E, low renin, low aldosterone, high ADH are already ruled out. High ADH, high urine sodium are characteristic of SIADH. It's a common cause of euvolemic hyponatremia. It's not hypovolemic. Low renin and low aldosterone are characteristic feature, but our patient is hypovolemic rather than euvolemic hyponatremia. Skin texture is reduced. Low ADH, low urine sodium, they are observed in patients with central diabetes insipidus. It typically presents with polyuria, polydipsia, normal to high urine sodium, okay, and high serum sodium. But in our case, is hyponatremia is there. Golden line to remember: hypovolemic hyponatremia occurred due to non-osmotic stimulation of ADH secretion in response to hypovolemia, hypotension, and decreased renal perfusion via angiotensin II. Restoration of blood volume shut off non-osmotic stimulation of ADH and corrects hyponatremia. Thank you very much.